Hi everyone, I'm Pauline, clinical oncologist practicing in UMMC. Today I've been given the task to talk about platinum eligibility criteria and the clinical application. So I'm unable to share my video, but just to put a face to the voice, this is what I look like and this is where I practice. So the goal of this lecture is to understand platinum and EV eligibility criteria and also its clinical applications, and these are the topics that will be discussed later in the lecture. Don't worry too much about this treatment landscape. I'm sure most of the speakers will have talked about this, but this is just to illustrate cisplatin has been around since 1978. And as time progresses, more and more treatment options are available. And as latest indication, pembrolizumab and enfortumab vedotin, or EV, has been approved in 2023. So why are we talking about eligibility criteria? Why does it even matter? I think it plays a huge role in determining the treatment options that are available to patients. So we talk about platinum eligibility first. It is to determine the access to neoadjuvant treatment in muscle invasive bladder cancer setting and also metastatic setting first-line therapy. And for patients who are ineligible, we need to think of other approaches. I know I have only been given to talk about cisplatin or more platinum ineligibility. However, I think with the new advancement, I think EV eligibility criteria also plays an important role. It offers a potent option after failure of first-line treatment, and also is increasingly used in immune with checkpoint inhibitors in earlier lines. And it is also an option for patients who are platinum ineligible. So just to talk a bit about platinum and its history, it is discovered by this man here, Dr. Barnett Rosenberg, and when they are carrying out an experiment on E. coli bacteria using platinum electrodes, and they realized that the cell division actually stopped during the chemical process. So this platinum compound is later identified as cis-diamine chloroplatinum, also known as cisplatin, and it was initially used in testicular cancer and subsequently led to discovery of other platinums, for example, carboplatin used in ovarian and lung cancer, and also oxaliplatin used in colorectal cancer. So this is just to illustrate the algorithms used in bladder cancer treatment as found in ESMO guidelines. And in muscle invasive cancer, you can see here that platinum eligibility is really important to guide your treatment management. So as of metastatic setting, you can see that in red on your right, cisplatin eligibility actually plays an important role to determine what kind of first-line treatment you get, and also those later lines after they have failed pembrolizumab, EV, in second-line setting. And you can see also here in yellow, EV actually has play an important role in the guidelines and also treatment selections in metastatic bladder cancer. Hence, I think it is of utmost importance to discuss about how we choose these patients in clinical setting. So let's dwell into platinum eligibility. The most common one used is Galsky criteria, which talks about cisplatin eligibility. So if you fulfill one of these criteria, then you are ineligible for cisplatin, with it being ECOG performance status of 2, creatinine clearance less than 60, grade 2 hearing loss and neuropathy. Lastly, NYHA classification of class 3 heart failure. Next is Gupta criteria, which determines not just cisplatin eligibility, but also carboplatin ineligibility, also known as platinum ineligibility. So if any one of these criteria are met, then you are ineligible for any platinum. These are ECOG performance status of 3 or lower, creatinine clearance of less than 30 mL per minute, and grade 2 or greater peripheral neuropathy, and YHA class 3 or greater heart failure, and also combination of ECOG performance status of 2 and creatinine clearance of less than 30 mL per minute. So to ease the comparison between both, I have found these guidelines from ESCO, and if you can see side by side, the criteria are quite similar for both, but the marked difference here is the creatinine clearance. If you are creatinine clearance is less than 30, then you're ineligible for any platinum. But if your creatinine clearance is between 50 and 60, then you are cisplatin eligible. So another easier one to look at is the ESMO guideline. As you can see on the left in the red box, it's basically the Gaussian criteria. And also on your right, basically that's the Gupta criteria. So you can pause the video to look at them if you want to. So next, when we talk about EV, firstly, we need to know some of its history. It's actually initially identified in 2000s, where Nectin-4 was found highly expressed on urothelial cancer and low in normal tissues, hence lead to the ADC technology and preclinical research, and first in human trials, and finally approved in earlier line use in combination with pembrolizumab. So when we talk about EV eligibility criteria, the main study that actually uses this is EV302 design, but I wouldn't go too much in depth about this clinical trial. And surprisingly, I found Dr. Enriquez, our esteemed preceptor, his ex profile, and he actually posted this not long ago about the EV ineligible criteria, also known as EVITA. And basically it's to identify patients who may not be optimal candidates for EV pembro combination if they meet at least two of the following criteria: HbA1c of 8 or more, grade 2 sensory or motor neuropathy, any corneal or retinal abnormalities, and creatinine clearance of less than 45 ml per minute, or ECOG performance status of 2. So I was wondering really, why the retinal abnormalities and why is there a limit of creatinine clearance being used in this criteria. And I found this interesting video where Dr. Enriquez spoke in a podcast. And if you're interested, you can listen to it in the link that I've attached below. Basically, their concerns are patients with poorly controlled diabetes mellitus would have consequences of this poorly controlled sugar, leading to diabetes retinopathy, diabetes nephropathy, that can potentially be worsened if EV was used, and causes further deterioration of sugar control. So I guess that's the end of it, but I would like to really showcase this final slide about this complexity of treatment selection for our patients. I got this from the cancer nursing practice, which truly indicates the amount of thought that should go in before we select treatments for our patients, from clinical guidelines, research evidence, and also previous experience in combination with tumor factor, patient's factor, social factors, and also patient's preference and priorities, ultimately leading to their expected health targets and health goals. And then it comes to between a tug of war between rational system processing and also intuitive system processing, and results in a treatment decision which should be holistic and patient-centered. So I think it's utmost important not to just think about what clinician wants, but also what your patient wants, and also to consider what are the potential complications, and also the result for their psychosocial factors as well. So in summary, this is just to illustrate that platinum is still plays an important role in MIBC or advanced or metastatic urothelial cancer now. So platinum eligibility determines the choice of therapy greatly in first line and also second line setting, and also in neoadjuvant setting. EVITA is useful, however, requires some fine tuning, as some deem it to be a really strict criteria, and some do think that may need some clinical judgment while using this criteria. So lastly, individualized management and tailored approach is really important. As you can see in the cartoons here, that we are potentially being replaced by AI, and maybe we'll be fired from our job one day. But I think what separates us between machines and human is that we are able to think and also fine tune and also empathize with our patients to include all the human criteria when we talk about patients' treatments and guidelines selection. Thank you.